Good afternoon, everyone, and welcome to the Futures Policy Forum, webinar number 5, Enhancing Community Capacity and Transforming Home Care and Community Senior Services. My name is Grace Meyer, and I am an Alberta Association Gerontology member and also the Secretariat for the Seniors Collaborative Committee. So really welcome everyone to today's webinar, and we're in for some really informative and enthusiastic presentations from our esteemed speakers panel today. Our discussion today is so relevant and important as we embark on enhancing and transforming home care and community senior services. There are increased needs for care and services in the community, not only because of the increasing number of older adults, but also because of more complex health needs, increasing longevity, and the desire of older adults to stay in their home community for as long as possible. In our work at a rehabilitation hospital, successful discharges are vitally dependent on wraparound care and support provided in the community. I am sure all of you join me in my interest and enthusiasm to hear from our esteemed panel members on this topic today. And this afternoon, we're going to focus on the second tier, around individuals with moderate to complex needs and providing that support in the community. So our objectives for today's session is to learn about best care practices in seniors care from other countries, specifically to learn about Denmark's delivery of seniors care using combined integrated housing and home care support, to discuss priority steps in needed transformation in Alberta, to learn about Alberta Health strategy in enhancing and transforming community and home care services and new delivery methods, and then to provide all of you to express your views and priorities on the role of community services in the transformation of seniors' health. Just a few housekeeping details. Please note that this webinar is being recorded for the future placement on AAG's website and YouTube channel. All participants are muted, so you will not be recorded. Please place your questions and comments in the Q&A box below your screen. Discussion with the speakers will take place after all the presentations have been completed, and this discussion will be facilitated by our webinar host, Jordana Bubar. And AEG is very pleased to have the financial support of a number of sponsors. So we will hear from one of our platinum sponsors in a few seconds, but I just want to acknowledge the generous support of our platinum, our gold, and our silver sponsors. I just want to also acknowledge the Alberta Association on Gerontology acknowledges its presence on the lands of Indigenous people across Alberta. We are committed to ongoing dialogue and shared learning to achieve healthy aging and quality of life for older Albertans. And now I'm going to turn it over to Mr. Leonard Frank, who's the Director of Strategic Initiative and Intelligence with Alberta Blue Cross, one of our platinum sponsors.
Thank you, Grace, and good afternoon, everyone. First off, just on behalf of Alberta Blue Cross, I'm pleased to welcome you all to today's webinar. Over the last 2 years, the COVID-19 pandemic has caused significant disruption to all of our lives. The pandemic has most significantly impacted vulnerable populations, especially our senior population. Many of the challenges faced by older Albertans, such as social isolation, inadequate or inaccessible supports, and threats to their health and well-being were exacerbated by the pandemic. However, in the midst of the pandemic, I think it's really important to recognize and reflect on the many individuals and organizations that stepped up to support our seniors and vulnerable Albertans. I'm proud to tell you all that during the pandemic, Alberta Blue Cross was fortunate to support some truly transformational work that is happening right here in our province to improve the care of seniors. We're a proud sponsor of the Healthy Aging Core Alberta, the knowledge hub for community-based seniors organizations and allied agencies and individuals in Alberta. This initiative was launched at the very start of the pandemic in May of 2020. In addition, we're also proud to have partnered more recently with Alberta Health and Alberta Health Services to support the administration of the client-directed home care program. I'm pleased to see that the lead for this project, Assistant Deputy Minister Corinne Sham, will be speaking to you later on this afternoon. I believe that we have the responsibility to find opportunities left in the wake of the pandemic to accelerate programs and services to improve the quality of life for our seniors and support aging in place in their community for as long as possible. Thank you for attending the webinar, and I'll hand the baton back over to Grace.
Thank you, Len, for your remarks and for your generous support of our webinar series. Okay, I'm going to do a quick outline of our speakers, but I will give a little bit more of an introduction as they are speaking. We have joining us today, Rosalie Wanch, Senior Policy Analyst with the C.D. Howe Institute, Mads Bering-Lacour, Director for Elderly and Dementia with the Danish Health Authority, Dr. Samir Sinov, who's the Director of Health Policy Research at Toronto Metropolitan Hospital and University's National Institute of Aging, and Corinne Sham, Assistant Deputy Minister, Continuing Care for Alberta Health, and Lisa Stebbins, Chief Program Officer of Carrier Alberta. So I am going to turn it over to our first speaker, Rosalie Wanch. As I mentioned, she's the Senior Policy Analyst for the C.D. Howe Institute in Ontario, and she will be speaking to us about the International Policy Insights, Continuing Care in Alberta. Continuing Care in Canada. So welcome, Rosalie, and turning it over to you.
Thank you, Grace. And also thank you to everyone for joining today. We'll just wait a second as my slides come up here. Okay, perfect. Just need control back. We'll just go back to the beginning here. Okay, nice title slide for our webinar today. And for those of you that might not be familiar with the C.D. Howe Institute, we are predominantly an economics-based think tank, and I lead the health policy research program. And as I'm sure you are all aware, a large portion of that program has been dedicated to seniors care and as well as COVID policy for the past 2 years. So this is an issue that's pretty close to my heart and that we've been diving into pretty deeply. So I'll just to jump right into it. The first place that an economist tends to look for when we're doing international comparisons is how much money do we spend? And so here I've just got the international comparison of per capita dollars that we put into inpatient and home and community care compared to other countries. As you can see, Canada is not super close to the top, but also, not the worst. But when you look at the balance of where we're directing care, Canada predominantly invests in inpatient care relative to home and community care, particularly when we look at some of the countries that are investing more than Canada, but as well as some that are investing less. Canada tends to invest more in inpatient care than in community care. As well, this slide compares dollars per capita. And when we look at it actually as a percentage of GDP, the comparison does end up looking a little bit worse. Canada, from a GDP perspective, does actually, fall a little bit short of the average. So this is about as rosy as the numbers can be, just to let the audience know that there are different ways that you can look at spending, whether it's dollars per person or proportion of our overall economy that we're dedicating to seniors care. On that front, Canada actually is quite low. And I think that as the population continues to age, the difference between sort of the senior population and what we're investing in seniors care can't continue to sort of be below average for the OECD countries. Also, we look at thinking of other resources that it takes to deliver good care to seniors. How many workers do we have relative to the number of people receiving care? And I should also mention that Canada is about average, a little bit below in terms of the proportion of people over the age of 65 that are actually receiving care. And underneath that, we also show as being this dotted line here would be roughly the average of the different breakdowns. And Canada is a bit below average in terms of how many workers we have for the senior population. But then just moving on to the breakdown again, it gets a little bit worse. We're about average for institutional care in terms of how many workers we have per senior, but we're basically dead last for the amount of workers that we have dedicated to home and community care. This other dot that we're overlapping, I believe, is Slovenia. And so that's roughly where Canada is in the international comparison. In terms of labor dedicated to home and community care, we're last. And I've also marked Denmark here, which is just basically right on the average line. And Israel is probably the furthest out in terms of the proportion of seniors both receiving care and the number of workers per senior. So just in terms of other countries for us to look at, we generally want to be looking at countries that are above or around the line. We definitely don't want to be below the line. And particularly in community care, we are actually pretty far to the bottom of the table. And so one of the things that I've also looked into is what's been happening since the beginning of COVID within Canada. It's pretty hard for anyone to look at the news these days and not see something about shortages of healthcare staff, which is really, looking at the international comparisons, probably our most dire sort of metric is if there's one thing that we need to do to improve home and community care, it would be simply invest more and have more workers. And so looking across the pandemic, I just wanted to point out, this is an industry breakdown. And with nursing care facilities, we do see some employment change, but for residential, we've got 1.9. Community care facilities and other residential care has actually dropped in terms of employment. And so really, this is a pretty complicated graph, and we don't have time for me to go through all the numbers or what they mean. But really what the broad picture I'm trying to paint is that within the labor shortage, the health labor shortage itself, we see workers moving away from institutional settings, as well as the community settings, and more into, say, outpatient care centers have had 43% growth and almost 12% growth in wages. Whereas residential facilities, wages increased about 22%, but they only managed to get 1.9% increase in staffing. Meanwhile, we have continuous growth in this population. So in real terms, the number of workers per senior that is requiring or receiving care is shrinking. And so I really personally, I'm focusing on labor as a particular issue in terms of recruitment and retention, because there is massive turnover. At least in Ontario, I've got the numbers sort of offhand, but we lose many, many personal support workers as well as nurses just year over year in terms of turnover, where people that have been in the profession for 2 years, about 25% plan to quit. And that number is also growing. So really, we can increase the labor force by recruiting, training more people. But if we don't stop the sort of burnout and people leaving the sector or changing to other areas of the healthcare sector, then it's likely that problem will continue. And then just thinking about how, actually, I'll just take a second before I dive into some more international comparisons, just to say that Canada's seniors care system, and I should really say systems, because we have different provinces, there's different policies, and even potentially different policies or availability between regions, that thinking of it as a uniform system is, a little bit painting over some of the some of the potential differences, and just that we have some equity issues in terms of access as well. So when we have a shortage of home care as well as a shortage of residential care, there are real concerns that there are care needs not being met, or that care needs are being met in sort of an inappropriate level of care. I've got some information about different countries as well, just to sort of warm us up on brainstorming and thinking about how we can do care differently. I won't spend much time on Denmark simply because, well, we've got some other panelists that will dive into it in depth, but I just wanted to maybe provide some highlights that every person over 75 is entitled to an annual preventative visit if they want to receive it. Assessments for home care form the care plan, but also a service contract. And within that, individuals have free choice of providers. So I'll let the other panelists really dive into the Danish system, but from an economist perspective, the combination of sort of universal access, a individualized care plan that also forms a service contract, and having free choice of providers are some pretty big highlights. And I also wanted to point out an interesting policy from Belgium, where really two aspects. One is a voucher model that isn't actually really, it didn't start as a home care service. It started as an employment program, but each adult in Denmark can buy up to 500 service vouchers. For those with disabilities, it goes up to 2,000, and they're low cost, about 10 euros each, and they're eligible for income tax credits. These vouchers can be used for all sorts of activities in and out of the home, cleaning, preparing food, shopping, and that sort of thing. When we're talking about home and community care, a lot of the time we like to equate it to healthcare. And since we're talking about those that may not be the highest needs level, there really is, we should think about unique or interesting ways to do that. And I'm now getting to the point where I don't have much time left. I've got to conclude. And so the other thing that I just wanted to point out from Germany is that they have achieved universal insurance coverage to cover the costs of LTC. And so just these are sort of some financing options, some different ways of looking at it, different policies that are sort of not traditional healthcare policies that we can look to internationally to get some ideas about how we could maybe tweak or improve or expand the Canadian home and community care sectors and systems. And with that, since I'm already over time, I'll turn it back to Grace for the other speakers.
Thank you so much, Rosalie, and thank you for setting the stage for us in terms of our current status, in terms of the labor force and where we're at in terms of funding community services. That definitely sets the stage for our discussion. So our next speaker is Mr. Mads Bering-Lacour, and Mads is the Director for Elderly and Dementia with the Danish Health Authority. And Mads is going to be speaking to us about Denmark's seniors care system and the role played by the home care program. And we're really looking forward to hearing a lot about that. So welcome, Mads.
Thank you very much, and thank you for the opportunity to speak about this really important subject. I would like to, in my presentation, to first of all give you some key principles on the overall structure and some of the principles behind the Danish senior care service and home care, of course. Then I'll go into depth more with what we actually do and some of the principles behind that. I will focus on home care and mostly on rehabilitation, because that has been one of the most one of the things we're focused on in the last 7 to 10 years. Then I'll just touch down on nursing homes just to show the difference, how little we actually use nursing homes, and I'll also just touch upon welfare technologies as one of the major parts, also in continuing with a big section of help actually staying in the home care services. Finally, if I have the time, I know we'll be strictly monitored on the time. If I have the time, I would like to just show you some of the discussions, the point of discussion in Denmark we have right now, at this moment, we have election in Denmark. So there's a lot of ideas of how to actually change the public sector in the future. And if I have some moments, I'll just show you some of the topics we are focused on in Denmark. So if I should start, I would like to just show you some of the principles, if I can get the slides to actually change. Here we are. Sorry. Hopefully that's right. Some of the key principles of the Danish welfare system. As Rosalie told us about, in Denmark we have a universal home care system and also universal healthcare system. That actually means that everybody in Denmark who are legally a citizen in Denmark has an access to services regardless of labor market status, nationality, or income. So you have everybody has the right to have this kind of service. We have one of the major acts who actually is the legal framework for the home care service, called the Social Service Act. Makes the framework for the home care system, the rehabilitation courses you can get in Denmark, and of course the nursing homes. We also have the Healthcare Act, where home nursing is a part of, which also set the framework for the GPs and the hospital setting. There's a lot of cooperation between these different acts and also between these sectors. And the Danish system is tax-based. And I think that's an important thing to just say at first. It's not insurance-based, it's tax-based. And there's not a lot of contribution-based services either. It is tax-based mostly. And the other feature I think is important to know about is that the Danish welfare system is very decentralized. We have 5 regions who has the responsibility for the healthcare system, and we have 98 municipalities who has the framework for the home care and elderly care services. They can themselves they cannot make laws. That is a national issue to make the laws for the elderly care, but they actually have a part of the tax-based. They can raise taxes to support the services in the municipalities. And to just continue, we have 3 different levels then. We have the national level, where I am working in the National Health Authority, where we make guidelines and we advise the Ministry on Health regarding the development of the home care services, for instance. We have the 5 regions where we have the hospitals, we have the GPs, and other kinds of healthcare services. And then we have the 98 municipalities. It is good to know that about 15 years ago, there was a large reform in Denmark, which really changed the setting of the home care system in Denmark. That was where you reduced the amounts of regions from 15 to 5 regions, and you also reduced the amount of municipalities from 271 to 98. And without that reform, we would be a very different place today regarding in developing the home care service in Denmark. And just to continue, what I'm going to say is actually pretty close to the principles from the WHO on healthy aging. The basic principles of rehabilitation and prevention as the most efficient ways to actually have a sustainable home care service and also healthcare service is very much in effect in the Danish way of going to look at the home care service and the services we provide. So you have the basic 3 trajectories you can see in the figure 2.2, and we want to try to make most of the citizens actually live a life where they can follow the part of pathway A here, where you don't actually have a decline in functional ability. That will, of course, not happen for everybody. But what we can do is we can try to, when there is some kind of incident, we can try to actually rehabilitate as much as you can to be able to live as long a life as possible with the less fall in functional decline as possible. So we use many of the same tools that is described in these kind of approaches from the international guidelines and such. So what do we do in Denmark? Well, we have 4 major parts of our senior citizen policy. First of all, as I've said before, focus on prevention and healthy aging. One of the things Rosalie talked about was the home visit, the preventive home visits, which everybody can get, where you have a holistic look at the housing, different kinds of aspects about the way you live as elderly in your own home, and problems that can be in the start where you don't need help from a municipality, but where you can, with simple actions, actually prevent that the level of there's a future need for care. So you can actually prevent a lot of things. The next thing is when you have a loss of function, actually very early, very quickly make a focused action regarding rehabilitation for the elderly. And that is normally combined. The two first perspective is combined with intelligent use of welfare technologies. So these are the major parts, and it's through the free home care services and nursing facilities where you can get these kind of services, of course. Just to give you an idea of how much home care you actually have in Denmark in comparison to other kinds of approaches. As you can see here, you have the proportion of Danish elderly population using elder care, and most of the elder care is actually, when you have 67 years and older, is in home care. And the nursing homes, it's very few Danish citizens who are at the nursing home. And we also know that the general time the people have in a nursing home is very short. I think it's a couple of years ago, the statistics, I know about how long you are in a nursing home. It's about 2.8 years general time at a nursing home after you have been a citizen there. So it's not something you use very often. It's really when you have you have a need for a lot of help that you get a place at a nursing home. So what are the categories of home care? It is, of course, practical help, which if you need some kind of assistance with cleaning and laundry and as such. It's personal care, different kinds, by bathing, shaving, and a lot of other care services like that, and food service. So that is the main categories you can get. You can also get home nursing care, of course. You have to get that on a prescription from your GP. But it is, again, the municipality who will then give you that service. So if we look at the home care service, how much do you actually get in hours as recipients of home care service? What you see here is the amount of hours and how many of the people who get home care service who get that amount of hours. Mostly, most of the recipients get less than 2 hours a week. And with that, you actually are able to live a life still in your own home, at your own, the way you want to live. You can see that then it's still a decline. It's a smaller percentage when you raise the amount of time. And we see a break off when people get more than 20 hours. It's not a good place to be in a home anymore. Then you normally will make a transfer to a nursing home facility. So there's a break even there where it doesn't really make any sense anymore to have home care service. But we try to let people stay in the home as long as possible. We know that that is what people want to do. They have lived there their whole life. They have the memories, and they have neighbors, and they have family close to you, and they don't want to move to a nursing home. When people move, they're actually glad, because at that point in life, they need so much help. They also need qualified nursing help daily in many hours. So they will, at that point of time, it will give them safety to go to a nursing home normally. Rehabilitation is one of the major, it's a major focus in the Danish healthcare system and in the home care system. And since 2015, the municipalities have been required by law to actually offer rehabilitation courses. And this is, I mean, you can look at paper and say, yeah, that makes sense, but this is a revolution in culture and in also the collaboration between different parts of the workforce around the elderly citizen and in the home care service. What we see is that it actually changed a paradigm from compensation to rehabilitation. And a lot of people who have been in the home care service doing practical help or giving a different kind of help regarding nursing, it's a big shift in the culture around the person to actually start saying, perhaps we have perhaps actually made a disservice helping people too much and actually kept them in a position where they couldn't become well again. So this is a major shift, and we see that it actually has a lot of impact also on the satisfaction from the elderly to the home care service. So that has been a major shift. And when you look at what is entailed, we have a process going from visitation to assessment to goal setting to follow up and targeted efforts to a termination of this kind of course. And if I should feature just one part of this as the most important, it is the goal setting. The goal setting is where you actually try to combine the citizens' motivation with the effort of the professionals to actually make a progress in the functional level. If you can find the right combination there, there's a lot of energy and there's a lot of focused effort where you actually can change people's life for the better and also make a more efficient home care service. We have a massive practical experience with rehabilitation. At this point in time, we don't have a lot of scientific evidence on how much effect rehabilitation have. We have scientists looking at it, and it seems like we get a lot of satisfaction, but we don't really have the scientific proof and the specifics on the effects of this kind of a massive transformation of the elderly care in Denmark. Hopefully we'll get more in the future. And just to say, you can have three possible outcomes of rehabilitation. You can have an elderly that are more self-reliant, who don't have a need for a home care service in the future. You can have somebody who is actually partly self-reliant, therefore has a reduced need. And then you have somebody who hopefully has an increased independence, but not reduced need. And all of those are actually successes. This is not just to get a more cost-effective home care service. This is also to improve the lives of the citizens. So there's a lot to say also about actually increasing independence as a goal in itself. Just to round it up, we also have nursing homes, as I said before. You have at the nursing home staff 24 hours by healthcare professionals. And we have, as I said before, relatively few elderly people living in nursing homes, as most prefer to stay in their own home. We are in Denmark now discussing whether we have to have some integrated offers before the nursing home. In Denmark, there is a fear of the nursing home in the senior part of this of the citizen population. We see that as when you need the help to get in a nursing home, you normally have a decline, not only in physical health, but also in the cognitive abilities and in the mental health. A lot of the people have different kind of cognitive impairment, dementia, and as such. So it is highly, it's something that needs professionals, and it's a special environment to live in also, even though it still is considered a home they live in. Just to round it up, a major part of all of this, that was one too far. A major part of this is also to combine these kinds of services and efforts with welfare technologies. Denmark is a very digital country. We have a lot of digital approaches to the citizens. One of the things we have really tried the last couple of years, also spurred by COVID, is different kind of telemedicine and different kind of screen solutions where you can have a different kind of interaction also digitally. We can do that in Denmark, but that's not the only thing. We have a lot of other things we try out right now. And many of these very small things is actually able to keep people at home and be able to live the life they want to do themselves. So this is an important part. I've just shown you some of the English-speaking, the English literature examples of the Danish elderly care and these different kind of assisted living technologies. So if you want to look more at it, you can do it there. My final slide, just to sum up some of the discussions right now in Denmark, because it's actually been very funny the last year. Canada has been really interested in the Danish healthcare system, in the Danish senior care system. And in Denmark, as it usually is, we don't really think we have a very good system. I think that is always the way things are. The grass is greener on the other part of your neighbor's land, and so is also in Denmark. So we have a lot of discussion regarding some of the same topics as Rosalie talked about before. Recruitment is a major issue also in Denmark. But here I've just listed some of the major things we discuss right now. We are, of course, also very inspired from other countries. Right now, we are very inspired by Holland and the Buurtzorg model they have down there with the interdisciplinary teams to enhance continuity and quality in home care services. We are trying some different projects in this line of thinking, and that is something the most of the Danish municipalities is trying in different forms right now. We also have a lot of discussion how to actually make attractive workplaces, not only talk about how to recruit and how to educate new workforce members, but also how can we actually continue to have them in this kind of setting without burnout, as also Rosalie talked about early on. We had a lot of discussion whether we have the right kind of documentation, whether we have too much documentation, whether the time used in the workday is used too much on documenting this kind of services. And then, of course, have we done enough regarding healthy aging and rehabilitation? How can we enhance it even more in our services than we have right now? And finally, to again also in new ways enhance our way to work with welfare technologies and digital solutions. So as I said, we have an election in Denmark right now. We're all very, very excited to see who will be the new prime minister in a month from now, and perhaps some of these things will change as also the political power will change. I think that was it for me.
Thank you so much, Mads, for that very interesting overview of the home care system in Denmark, and it certainly gives us something to strive for with your over 10% of your labor force in the area of community. And it's also interesting to note that that you see yourselves as still having a number of challenges and similar challenges to us in terms of workforce, in terms of the documentation and how much time is being dedicated to that, and then getting the right technologies. And certainly, I think we have those challenges as well. So thank you very, very much for your presentation. And we're going to move on to our next presenter. And Dr. Samir Sinha is the Director of Health Policy Research at Toronto Metropolitan University's National Institute of Aging. He is the Director of Geriatrics at the Sinai Health System and the University Health Network. And Dr. Sinha is going to be speaking with us today on his topic of enabling a promising future for continuing care in Alberta. Welcome, Dr. Sinha.
Thank you very much, Grace. And again, it's a pleasure to be here and to join my esteemed colleagues as well. In full disclosure, I'm at Toronto Pearson International Airport, and I have a flight to catch that starts to board before the end of the webinar. So I'm not going to be rude if I have to, if I'm being forced to get onto a plane, but I did not want to miss this webinar because this is a really important conversation, and I'm really proud to be a part of it. So onwards with the presentation. So I was going to speak a little bit about thinking about how we can enable a promising future for continuing care in Alberta. And I was recently at the Continuing Care Association conference recently, where it was just great to see the energy as people are starting to think about what could be next in terms of how we provide care. So we know that in light of the pandemic, and what we've done is we've found when you survey Canadians in terms of what their preferences are, this is one that we did in partnership with TELUS Health back in June of 2020, just really after the first devastating wave. And we found that 91% of Canadians of all ages, but almost 100% of Canadians, and I could say you could put Danes, you could put Belgium, you can put Germans, whomever you want in there, basically report that they plan on supporting themselves to live safely and independently in their own homes for as long as possible. So we know this is what people want. And we know that if anything, the pandemic has really shifted our perspectives. At the NIA, we've really been focusing on these issues around thinking about how we need to have a national senior strategy. We don't have one currently in Canada, and how it really needs to focus on kind of key things that are really important to Canadians. And I'd say pretty much in any country. How do we support people to remain independent, productive, and engaged citizens? How do we enable everyone to lead healthy and active lives to support healthy aging? How do we enable more care closer to home, given it's what people prefer and they want? And how do we not neglect the needs of caregivers? We have 8.1 million of them across Canada, and 1 in 3 people participating in the labor force is also an unpaid caregiver. And you may have heard the recent stat from the Alzheimer's Association in Canada, which shared in their recent study that the average person caring for a person with dementia is spending 26 hours a week providing unpaid care. That's almost a full-time job. And this is a group that we need to think about as our population ages. So we've been doing a number of studies going back to 2019, looking at enabling the future provision of long-term care, and also thinking about the future costs of long-term care overall, because it's one of those sorts of things where we talk about the problems, but we don't necessarily think about what exactly could the future look like if we don't change the way we're doing things, and what's the benefit of actually enabling a more promising future as well. So when we think about long-term care, and I think you've heard this theme already from Rosalie and Matt's talk as well, is that often when you sometimes hear the term long-term care, you might think of just care in nursing homes or institutional settings. And really, we created a definition that really helps to try and think about how the OECD, the World Health Organization, even in the United States, people look at long-term care as something that can be provided in a variety of locations, in your own homes, all the way to in, say, an institution institutional setting like a nursing home. We've heard a little bit about the Danish approach, about this focus on prevention and wellness, but also being responsive to people's care needs and thinking about all levels of support, not just supports with bathing and dressing, for example, but also helping people with things like housekeeping and meal support. All these sorts of things encompass what we think about long-term care. And when we have that more holistic approach about where it's provided, just how do we actually provide this variety of services and supports. So long-term care matters because it's the largest form of hands-on care that's not covered under our Canada Health Act. And we know that coverage levels, qualifying criteria, design standards vary significantly across our provinces and territories. We have, at least 13, maybe even 14 different kind of forms of long-term care systems in Canada, and not governed with a national standard or expectation that all Canadians can actually think about. And we know that many are seeing now that the value of long-term care is important, especially when we're thinking about meeting the needs of an aging population effectively and sustainably. Yet we have an unprecedented demand for this care, and it's only going to grow as the population ages. But our system has been plagued, as Rosalie spoke about, with longstanding systemic vulnerabilities, with health human resources, but also physical design and redevelopment approaches. We heard a lot about the types of homes we have, large warehousing institutional settings, for example, which became problematic in terms of how they were encouraging the spread of COVID-19 in these settings. And naturally become places where influenza really takes its toll every season, maybe something we've taken for granted. So is it possible? How possible is it to age in the right place? Well, in 2015, there was a national survey that was done. So this is well before the pandemic, saying that 63% of respondents said that their family was not in a good position financially or otherwise to care for older family members if they needed long-term health care, and it worried them greatly. So we haven't been doing a good job to prepare Canadians financially, or also recognizing that family structures and even where we live are changing, especially across our vast country, making it really challenging for people to provide the care they want to their loved ones who might actually need it. And what Rosalie spoke a little bit about the challenges that we have in terms of capacity, because right now we have over 430,000. This is actually 2019 data. So now we know it's well over 500,000 Canadians currently report having unmet home care needs. And actually that number is no longer 40,000, it's 52,000 as of last year, are currently on nursing home wait lists. And you can imagine if you can't get care to keep you in your own home, well, where do you end up? You end up in an emergency department. You end up staying in a hospital until they can find a nursing home that you can go to. And right now, if you're waiting in hospital in Ontario, it's about a 4-month wait list on average to get into a nursing home if you're waiting there for one. So we can obviously start seeing the challenges, and I'm not going to go into this in detail, but the bottom line from these slides that you'll see, these next two, is again that when you look, as Rosalie was saying, where Canada ranks in terms of what proportion of our GDP or our gross domestic product we're spending, we're a little bit below the OECD average, for example. So we don't spend as much as other countries, such as Denmark, all the way to the left on the third from the left. They spend about twice of what we spend in terms of GDP spend on the provision of long-term care. That's care in people's homes, but also care in institutional settings. And as you heard already from Rosalie, when you actually look at how we spend our dollars, the vast majority of our long-term care dollars are spent on institutionalizing Canadians, with a very small proportion on helping people stay in their own homes and communities. Again, if you go to the extreme right of your screen, you'll see Denmark there, where the majority of their long-term care spending goes to supporting people to stay in their own homes, rather than institutional settings. So it really just shows that when we start looking at different countries and kind of say, well, what are they doing differently? Remember that the key difference, as I always point out, with a country like Denmark versus Canada, they spend about twice their GDP of spending on long-term care that we do. And then the majority of their funding goes towards the provision of home and community care, where it's the opposite here in Canada. So really different approaches showed really different outcomes. So we know as well that between now and 2050, the number of people who are going to be requiring services and supports are going to grow. And in fact, the cost that we're spending publicly right now, if we do nothing differently, will grow from $22 billion in 2019 to $71 billion. And that will represent 1 in 4 income tax dollars that's collected at the provincial and federal levels by 2050 if we do nothing differently, if we have the system that prioritizes institutionalizing people. Because frankly, as we age, people will need care. And if we're not prepared to care for people in the best possible and most cost-effective ways, we're going to be spending a lot of money caring for people in inefficient and non-effective ways, for example. So the other challenge is if we think that we're just going to rely more on family members to pick up the slack, we have to remind ourselves that there will be 30% fewer close family members available to provide unpaid care 30 years from now, mainly because our birth rates are declining. And also we have a geography where people are living further and further apart, for example. So we know that if we're going to have lean on family members to continue providing unpaid care, the remaining caregivers are going to have to increase their productivity by 40% to meet the current unpaid care duties that they are relying on. And this is about a $10 billion value when you look at the amount of unpaid care being provided to older Canadians by family members and friends. So finally, what I wanted to just mention was that when we start thinking about how do we think about a framework for supporting long-term care, our report from 2019 really kind of laid out a bit of a framework that looked all around the world for leading models, including looking at the choice program that you have in Edmonton and other models from Denmark and other parts of the country, the United States, and around the world, thinking about what are the things we can do to support people to stay independent in their own homes for as long as possible, things that can really promote staying healthy and well. How do you help people then navigate their communities if they need a little bit of help? And then how do you think about the models of care we might need, ideally in institutional settings, for example, for those who end up needing to be in a long-term care home? There are many things that we can do, many great evidence-based things that we could do if we put our mind to it. And again, these are the things that I'm glad to see that Corinne and others are going to speak about what's being considered right now in Alberta with some of the current continuing care reforms that are being considered. So there's a lot of excitement, and I actually have a lot of hope for what Alberta will be able to achieve over the coming years. Finally, the question becomes, I saw one of the questions was saying, like, why are we not actually making any meaningful changes? Because we know that right now, when you look at the math, it's about $750 a day when we have people waiting in our hospitals to go home with home care or to go to a long-term care home. We know it's about $750 a day. And currently in Ontario, we now have 6,000 citizens who are waiting in our hospitals who cannot get home. It's the record number ever before. Only 40% are waiting for nursing homes. The biggest reason we have so many people waiting in our hospitals today is not enough home care. We know that those waiting for long-term care are waiting for something that costs about $200 a day, whereas home care for a long-term care equivalent person costs only $103 a day. This is the government of Ontario's own data. So they show what it costs. And you've heard a little bit about Denmark, but Denmark, as Mads was saying, made some deliberate policy choices decades ago, saying we're going to actually invest more in our home and community care services. And by doing that, avoided building any new beds, long-term care beds, and actually were able to close thousands of hospital beds because they didn't have the ALC crisis that we're having here. And what we did in Ontario between 2011 and 2018, I think to answer one of the questions, was we deliberately took a Danish approach, if you will. We started increasing our home and community care budget by 5% a year over year between 2011 and 2018, about $1 billion more in home care. But with the most recent government that came into power in 2018, they reduced that increase back to an inflationary level. During that time, our home care waitlist have now quadrupled in Ontario, and our long-term care waitlist has now topped 40,000 people. So the key is, while this current government in Ontario is focused on building 30,000 new long-term care beds, We do have evidence of what actually investing more in home care can do. We've actually done it here in Ontario. And what I want to show you quickly with this graph is the blue lines represent the number of people 75 and older living in our long-term care homes. So it's been fixed around 76,000. And this current government in Ontario likes to say how during this period, the previous government only built 611 new nursing home beds. What they don't tell you is what the purple lines tell you, that the previous government put $1 billion more in home care. They followed Dr. Sinha's advice, and lo and behold, the purple bars represent people who are long-term care eligible, but now able to stay in their own homes because we have more home care available. And what you could see over the years as you go to the right, we now have more long-term care eligible people able to live in their own homes with government-funded home care than are actually living in our long-term care settings. And as of 2021, that number is now 130,000 Ontarians, almost double now the number of people living in our long-term care homes. So is policy change possible? It absolutely is.
Dr. Sinha, I apologize. Our time is up, and I don't want you to get muted prematurely. So thank you so much for that that great talk, and certainly gives us lots of food for thought to the changes that that we need to consider. And I also just want to say thank you so much for squeezing us into your travel schedule and providing opportunity for us to hear your remarks. And hopefully we can address some of your key points during our question and answer period coming up. So to move on, we are going to hear from our next speaker, Corinne Shum, and Corinne is the Assistant Deputy Minister for Continuing Care with Alberta Health. And Corinne is going to be speaking on Alberta's strategy in integrating continuing care services and enhancing home care capacity and innovation. Welcome, Corinne.
Thanks very much, Grace. See if the slides will move here. Alrighty. Thanks to all the previous speakers, and I'm sorry I didn't get to see what Dr. Sinha was going to say about Alberta, so I'll have to follow up with him later. You're starting to hear some of the common themes, I think, across the speakers so far, and that'll continue as I zoom in now on our province. Both Rosalie and Dr. Sinha mentioned that Canada spends proportionately less on home care than other countries. And the maybe not so good news is that within Canada, Alberta sends a proportionately smaller amount than the rest of Canada on home and community care than other provinces. Alberta is the red bar there. So the good news is we've got a lot of room to grow in that area. The limits on availability of home care are particularly evident in rural communities. Dr. Sinha spoke also to caregivers, and we know that the reliance on unpaid family and friends is resulting in caregiver burnout, and that's expected to continue as the number of caregivers decreases due to smaller family size and increasing mobility. Right now, Alberta's continuing care system supports approximately 60% of our continuing care clients through home and community care, and approximately 40% of the clients in continuing care homes, or as we call them in Alberta, long-term care and designated as supportive living. Based on the preferences of Albertans to support their quality of life as well as system sustainability, our target is to move from 60% being served through home and community care to 70% over the next 10 years. And that would mean that approximately 10,000 more Albertans will receive the care and supports they need at home than if we continued in the proportion of 60-40 that we now have. There's many components that make up the overall transformation of continuing care, and the light blue is highlighted there to show you the specific parts of this continuing care transformation that are focused on home and community care services to meet the current and future needs of Albertans. This slide shows some of the major components of the continuing care transformation that's underway, and it's being informed by findings from the facility-based continuing care report that was released last year, as well as the palliative and end-of-life care engagement report released last November. The new legislative framework provides the policy background for the changes that residents and families and operators are going to see in practice. This new framework will enable the integration of all continuing care services, including home and community care, which will pave the way for innovative approaches. Like Denmark, we are moving to one piece of legislation across continuing care. Our current legislative framework is very complex. It comprises content from 6 acts, 6 regulations, 3 sets of standards. Some of it dates back to 1985, is no longer accurately reflecting our continuing care system. And so given all those challenges, we have put together one new overarching framework, a new Continuing Care Act. It received royal assent on May 31st and is intended to be framework legislation. We are now working on the next step in the process, which is developing the regulations and the standards. So specific to home care going forward, government has worked collaboratively with key stakeholders and community-based partners to identify some strategic goals for enhancing home and community care as the key foundation of the continuing care transformation. Key objectives include investing more resources in home and community care, making it easier for Albertans to navigate and access the different types of care and supports in the community, empowering clients and families to be more active partners in their own care with more flexibility and choice in determining how their care is provided, and improving the coordination and navigation of care across multiple healthcare and community programs. This work has already begun, and just a few examples. We're working on enhancing client-directed options through the home care program. At the very beginning, Len mentioned implementing a new invoicing option supported by Alberta Blue Cross. We've implemented in Edmonton and are now moving that out to other parts of the province. Fostering innovation in the home and community sector through a recent call for expressions of interest to help identify potential new partnerships and innovative ideas that can improve client outcomes. Third area is expanding access to palliative care supports in the place of choice of clients. And fourthly, funding for caregiver supports. Enhancing client-directed care enables clients to choose their own care provider. They can organize services around their own lives, including their preferences and their schedules. They can choose the providers that best meet their needs. It might be language needs, might be culturally appropriate care, might be small local agencies that can provide more consistent care staff. Earlier this summer, a request for expressions of interest was opened for home care providers to submit proposals on how they could help improve home and community care service. And this process is designed to foster innovation in the system and identify opportunities to improve outcomes, in particular for specialized populations that sometimes are not well served through the standard home care program. Might be complex clients, palliative end-of-life care clients, or clients living with dementia, for instance. Lisa will be speaking next to the non-medical supports, but just a couple of recent examples of new funding include the provision of non-medical supports in Calgary through the United Way, and Edmonton Seniors Coordinating Council that's helping home care staff who identify needs for non-medical services with their clients, and they're helping them connect those clients to community link workers to help those clients navigate and access available resources. So we're testing out a variety of new initiatives in this area for further expansion around the province. I mentioned focus on palliative and end-of-life care. Sorry for the acronym, but that's what the acronym stands for. The government committed $20 million to enhance this area, and a good portion of that funding is targeting community-based programs and services to support Albertans living with life-threatening illness to remain in their homes and communities. And so a call for proposals went out, and we have 25 innovative programs operating around the province. And again, the idea is to spread and scale those. As we look to the future, some of the other innovations that we'll be looking at, but certainly not limited these, just some examples, looking at continuing care homes as perhaps community hubs. So there might be in a small community or in a cultural community, a home that could actually reach out into the community, providing adult day program services, perhaps home care services, meals, and so on. Looking at expanding client-directed care models beyond home care, perhaps. Enhancing the integration with primary care. Increasing palliative and end-of-life care supports, including hospice care, and looking at different ways of delivering care, such as who provides the care and the location of care. So just finally, our next steps. This fall, we are expanding some of those home care initiatives that I've spoken about. So those are underway and being monitored to determine which ones to spread and scale. We have external stakeholder engagement going on around the regulations and standards and how to implement those, and that includes for home care. We are looking at potentially next spring for the new Act, regulations, and standards to come into effect. Work will continue to support the implementation there. The timing, of course, is going to be dependent on the government agenda moving forward. Mads mentioned their election process, and of course, Alberta is in a similar scenario right now. And looking at, once those are in place, looking at the expanding home and community care with some of the innovative proposals we're excited to take a look at, updating the contracts there, and advancing home and community care with some of those proposals. Back to you, Grace. Thanks very much.
Thank you, Corinne, and thank you for setting the Alberta stage. And we're certainly appreciative of Alberta Health's commitment to transform senior services in continuing care and community care. So thank you so much for that. And also, you know, that focus on innovation and exploring new ways of delivering things. So thank you so much. And certainly, at last, but certainly not least, Lisa Stebbins is the Chief Program Officer for Carrier in Alberta, out of Calgary. And Lisa is going to speak to us about community-based senior serving organizations, part of the solution. So turning it over to you, Lisa.
Thanks, Grace. So thank you to AAG for the opportunity to share some of the work we're doing with Healthy Aging Alberta and how community-based senior serving organizations are part of the solution for enhancing community capacity and transforming home care and community services. Organizations serving older adults play a critical role in Albertans aging at home and in the community. Coordinating our efforts is a key step in meeting the needs of the growing demographic of older Albertans. The context and the challenges is likely familiar to many of you in your work and from previous presentations. So as you know, the population of seniors in Alberta continues to grow faster than any other age group, and older adults in Canada overwhelmingly express the desire to stay in their own homes as they age. Unfortunately, many seniors can struggle to age in place and continue to live in their communities, not because of the need for medical services, but because of a lack of reliable, accessible, and coordinated non-medical supports. These non-medical supports, like assisted transportation, home maintenance, service navigation, social connection, and financial supports, are offered less consistently across Alberta than medical supports through the healthcare system. There are thousands of community organizations doing excellent work in the senior sector, offering critical services that support healthy aging. Unfortunately, there's very little integration among these services or with other sectors such as health. This is due to many factors, one being diverse funders for these services. Some are funded by FCSS, maybe United Way or local community organizations or other grant streams. Also, organizations operating these services have a variety of capacity. Some are led by grassroots volunteer groups, others by nonprofit organizations. Some are even offered by the municipality or the private sector. There is also distinct needs related to local contexts, particularly in the differences between rural and urban areas. The community-based sector is not currently well-resourced or integrated into the larger senior system of care in our province. This lack of provincial coordination, working in isolated clusters, and the lack of sustainable resourcing for this sector means inadequate community-based service delivery. Preventative community-based care is in fact the solution that will allow older adults to thrive while aging in place and improve their health and social outcomes, which in turn will reduce health system costs. This context is the driver for the development of Healthy Aging Alberta. Healthy Aging Alberta focuses on the development of a coordinated community-based senior serving sector that is respected and integrated within the broader senior system of care and can empower and inspire every senior to age how they choose, ultimately improving health and social outcomes for older adults. We hope to create the bedrock for healthy aging in our province by building a provincial network that connects the sector's organizations so they can collectively advocate for healthy aging on a provincial level, share knowledge, and create functional relationships with one another and our system allies in health, housing, and other sectors. Community-based senior serving sector is the third sector representing community supports, working alongside the housing and health sectors. Together, we form a strong base and foundation within the broader senior system of care. Working system to system, we now have the opportunity to have a more fulsome discussion around non-medical based supports. Prior to the formation of Healthy Aging Alberta, we did not have a mechanism to facilitate the conversation around primary and secondary prevention, alongside more complex models of intervention, encompassing all aspects of the community-based sector within a broad spectrum of care. The advantages that we have in Alberta involve having a single health authority and the inclusion of a unique FCSS infrastructure in place. The challenge in Alberta is that work is required in building toward an integrated system, especially as other jurisdictions have more integrated government, health, and senior services. Right now, we are leaning heavily on an interministerial approach with a lot of support from sponsorship to make this work progress. However, that's not where the funding lies. To support the advancement of this work, the provincial government has already made an initial short-term provincial investment in community in the home support space that will be facilitated through Healthy Aging Alberta, as well as more targeted investments in the social prescribing space to advance this concept in Alberta. I will highlight one of these projects that my organization is a part of. The Way In, a collaborative of 4 agencies in Calgary, has an aging in community supports project underway since the fall of 2020, with investments from the Ministry of Seniors and Housing, the United Way of Calgary and Area, Alberta Health Services, Healthy Aging Alberta, and Alberta Health. Due to existing work with the Home to Hospital to Home Working Group in the Calgary zone and the strong support of primary care networks in Calgary, the project began with a focus on establishing referral pathways with PCNs across the Calgary zone, using existing infrastructures within the individual PCNs and some of the acute care sites. A client or patient profile of individuals who could benefit from the services of an outreach worker and further connection to community-based services has also been developed, which includes vulnerable older adults aged 55 and over, individuals with limited natural supports, individuals who may require non-medical supports to age in community, individuals that are referred by a health professional with a broad interpretation of that. It could be a physician, a social worker, a nurse navigator within the health system. And to date, we have received 527 referrals with 484 intakes into the program. The top presenting issues have been information or system navigation, social inclusion and learning, food security, and mental health concerns. Upon referral, the outreach worker works with the older adult to coordinate a plan to support independent living in a community setting. Plans include connecting low-income seniors to benefits and income supports, supported referrals to in-home supports like homemaking, snow and mow, grocery shopping, friendly visiting, and essential transportation. Also includes stabilization of housing, supported referrals to social connection programming, supported referrals to mental health supports, and interface or connection with the PCN to support the health needs. Supported referrals are a more hands-on approach in assisting individuals to access supports, which may include making phone calls together, assisting with applications, or accompanying individuals to appointments or programs. I'd like to share a story from this program to give you a sense of the work that we would do in this program. The outreach worker received a referral from a PCN stating that Henry needed seniors housing due to a recent divorce. Henry is 70 years old, lives with his ex-wife where he occupies the basement of the home. The outreach worker set up a time to visit Henry, but he didn't want them to come into the house, so they did the intake in his truck. It was clear that Henry was embarrassed about his living situation. After talking with Henry for 2 hours in the truck, he finally allowed the outreach worker to see the basement of his home. He explained that once he moved from the basement, the house would belong to his ex-wife. When the outreach worker entered the basement, she saw that he had a reclining chair, a bar fridge, and a hot plate, which was in a small corner of the basement. The rest of the basement was packed with old carpets, old cabinets, and other discarded items. It appeared that renovations were done upstairs and everything was moved downstairs for storage. The bathroom downstairs had no running water, so he had to go upstairs to use the bathroom and shower. His mobility is moderate and he uses a cane to go up the 2 flights of stairs. It was clear that the living situation was not meeting his needs and may be impacting his physical and mental well-being. His only joy was a bookshelf where he explained that the books were ones he had read or wanted to read. The outreach workers started the process of applying for housing. Henry really didn't know much about housing options, but with the help of the outreach worker, they determined together that he wanted independent living at an affordable price for his limited income, and he wanted to be located in the Dover or Forest Lawn area where he had friends and liked to attend the Ogden Seniors 55 Plus Center. After touring one option with his outreach worker, Henry said he loved it, and the outreach worker assisted him with an application for affordable unit at that site. He moved in within 2 weeks and got some help with furnishings for the apartment. When the outreach worker went to visit him at his new apartment a month later, the people in the foyer knew his name and he said he loved it there. He had a spacious kitchen filled with food and he had 2 bookshelves, one with books he had read and one with books he wanted to read. He said that he loved living there and couldn't believe how affordable the rent was. He said he was so happy and his appearance was also improved. He was well groomed and had a beautiful blue shirt on, a sign that he was in a much better situation now. Henry thanked the outreach worker and said he felt like he'd gone to heaven. He even told the outreach worker that he had women in the building hitting on him, which he loved. In conclusion, we want to leave you with a sentiment that's been shared with us about this work. And that's all for me.
Thank you so much, Lisa. I really appreciate you describing the very, very important role that community agencies play in supporting our seniors. So I'm going to open it up to our panel presenters to address one really important question before we get into any time left that might be available for other questions from our audience. What is the one most important thing to do in order to transform the home and community services system in Alberta? And I was going to call upon Dr. Sinha, but unfortunately his flight has started to board. So perhaps we can hear from Mads, our international guest, about what he feels would be the most important thing for Alberta to do.
Oh, that's a very big question. I'm not sure I'm really dressed to answer that question, not knowing more about your system. But I can say I agree with Samir regarding the timeline you also have to have, creating this kind of move from long-term care facilities to long-term care in the house. It will be a journey you start. It's not just from one day to another. And I think the approach they had tried by year for year, adding the amount of home care regarding the long-term care in nursing facilities was a good approach. The second thing I would like to say is in Denmark, we also have a lot of community agencies, and it's extremely important part, besides the other parts I talked about, to have that kind of citizen-based, community-based activities. We have that in Denmark, a lot of that, and that is one of the main reasons people are able to avoid the traps of elderly living at home, which is most of all loneliness and not being able to get out, not being able to actually have physical activities still at the amount you can, stuff like that. And there is community-based approaches is extremely important to make meaning and sense of that kind of activities. So just to say, I agree with you, Lisa. This is extremely important to look at too, how to actually promote healthy aging and community-based services.
Thank you for that, Mads. And for many of our other panel guests.
I've got a real short one. I would say in addition to stimulating community-based approaches and really just leveraging anyone out there that wants to be involved and wants to help, my very short but complex answer is money and people. We don't invest in the sector. So if we don't invest in the sector and we don't encourage growth in the sector, how can we really expect it to thrive? You know, being an economist, we don't really, some people are uncomfortable thinking about healthcare as an industry, but at the end of the day, care providers need to be paid. The people that run these companies need to be financially viable. Even if they're nonprofit, they do need to be able to pay their people and maintain operations, and hopefully actually have a little extra to be able to invest in improving and innovating care. And without sort of a mechanism for innovation and simply the money to get us to an acceptable baseline, I'd start there.
Thanks for that, Rosalie. For many of our other panelists. And Jordana, is there any question, any themes coming out of the Q&A that we should pose here in the next few minutes?
There have been quite a few questions answered by our wonderful panelists already. We can address some of the bigger ones, or you can go ahead and ask your final question and get the panelists rolling on that.
And that was exactly what I had just done, Jordana. So if there's one question that that pops out from the inbox, if you want to just pose that for the panelists to address.
Maybe while that's happening, I'll say my one thing would be start now.
Yes, thank you. Thank you for that. And Lisa, Lisa, do you have any additional comments?
No, I think everyone captured it. I think we need to shift investments to include what community-based organizations are providing in that support. And that really we need to also understand that not everyone has a family system that's helping them navigate the health system or can support them. And so I hope my client example showed you that really even just applying for housing or those supports need to be given to individuals, because it's not an easy system to navigate without any supports. And so really having that system navigation support is important as well.
Excellent. Thank you. Thank you. Thank you so much to our panelists for an excellent presentations. And it's clear that we need to certainly look at how we can focus on enhancing our supports in the community, both formal supports and care in the community, including rehabilitation, which is music to my ears specifically, but also those other supports like household supports that enable people to stay in their own home. Certainly looking at the labor force, and I know that there's plans underway in AAG to look at some possible avenues to get people thinking about new strategies to enhance our workforce. And certainly the other piece is around caregivers and the role of the caregivers, family members, and others who support individuals in the community, those unpaid caregivers. And that's certainly a very, very vital part of the care that seniors are receiving. So just in terms of wrapping up, I want to invite you to visit our website, albertaaging.ca, for our future webinars to make sure that you're registered for that. And also there is an opportunity to become a member of AAG. So please look for that on our website. Following our webinar today, that you will be receiving a survey asking for your feedback, and we certainly look forward to receiving that. That feedback is reviewed at our stakeholders advisory council. So please make sure that you respond to that. And our next webinar, our 6th Futures Policy Forum webinar, will be around supporting caregivers with service and policy change. And that is slated for January the 18th. And there will be some further announcements on that. Again, please check our website. So as you know, as we've been talking about, caregivers provide 75 to 90% of the care to children and adults with complex chronic needs and disabilities and frailty. And yet caregiving can put the family caregiver's own health and well-being at risk. So how this webinar will focus on how we support family caregivers to care and maintain their own health, as well as enable Albertans dealing with illness, disability, and frailty to remain in the homes of their choice. So please join us for that webinar on January the 18th, and we'll hear from a panel of experts on theories and data on the value of family caregivers and the importance of recognizing family caregivers' work. So I want to, in closing, again, thank each and every one of our panelists for great presentations, and each and every one of you for participating in our webinar today and for posing your questions. And hopefully they were answered during the course of our webinar. And if not, we will certainly follow up with those. So thanks again, everyone, and be safe.